challenges. It's my pleasure on behalf of LensGen to introduce a panel that we have today entitled, What Do People Want? The Current Debate of Quality versus Quantity with Premium IOLs. And I have a very distinguished panel with me today. My name is Sam Garg. I'm from the Gavin Herbert Eye Institute at the University of California, Irvine. And with me today, I have panelists Eric Donenfeld from the Ophthalmic Consultants of Long Island, Rosa Bragamili, who's in the Kensington Eye Institute in Toronto, Vance Thompson, who is Vance Thompson Vision, and Elizabeth Yu from the Virginia Eye Consultants. I'd like to thank LensGen for sponsoring this live webinar, and thank the team from LensGen, particularly the CEO, Ram Rao, Mike Landerville, the COO, and Patrick Casey, who's head of clinical and regulatory. So before we move too much, I'm just going to discuss the technology a little bit, and we'll go over this here, and then we can talk about it as a group. The Juvene lens, for those who don't know about the lens, is a modular lens. It has two parts to it. One is the base lens, which fits into the capsular bag, and there's a fluid lens, which actually changes curvature. These two come together, and when they come together, you have your entire optical system, and it gives you full range from distance to near by capitalizing on the natural, see here, the natural mechanism within the eye. And you can see here a schematic of how the lens works. The natural Helmholtz mechanism of ciliary contraction and relaxation allows for the bag to move. This then allows the central optic of the Juvene to change curvature, which allows for vision from distance to near. So we have two teams, and this was done randomly. We had a random drawing, and the two teams are Eric Donenfeld and Elizabeth Yu will be team 1, and Rosa Bragamili and Vance Thompson will be team 2. So we designated team 1 as team quality, and team 2 is team quantity. Well, we asked our yes, go ahead.
We know there are two definite losers here.
It's nice of you and Liz to bow out so early.
We're not talking about Vance and Eric here.
No, the losers are Liz and Rosa, who got stuck with the two of us.
Oh, that's true. That is true.
So we decided to have a little fun with this, and for team quality, they named themselves the Angels Without Halos, and for team quantity, the Full Rangers. And the Full Rangers are the Power Rangers here, and obviously Liz is the true angel, and then we have Eric. These are our two teams, and I thank you guys for the team names here that you provided. So as we get into this, we have some panel questions that I wanted to ask you guys, and I'll first start by asking Liz, when it comes to an IOL technology, whose perspective is most important? And how do you discuss the expectations for a particular IOL with your patients?
With any cataract evaluation, it's really the patient's perspective that's going to be the most important, because what they want, coupled with their comorbidities and their actual health, plus in combination with the conversation with the surgeon, will then determine what lenses that they actually qualify for, and then ultimate recommendation on what is potentially best for the patient in their specific scenario.
Yeah, and how do you discuss expectations for a particular lens? Do you do that yourself, or do you have someone in your office do that? Do you use any aids?
Yep. So the patient education piece about what is a stigma or what is a cataract, those kind of pieces, we do have the patient counselor go through that information. So they have a basic level of education between what they're getting before the clinic, plus what they're getting in that cataract and astigmatism and what lens options are available before they meet with me. But setting the expectation, that is really talking about the benefits and truly spending even more time potentially on the side effects, coupled with just seeing what their personality is like, is going to really help create the conversation. That conversation is going to have some objective rapidity from patient to patient, but it truly is going to be customized for that specific patient's portfolio, if you would.
Great. And Vance, what does patient satisfaction mean to you, and how do you measure or quantify it?
Well, the simplest explanation is that when it comes to, their vision, it just fits into their life. It's not a hassle. There hasn't been a big adjustment. And sometimes even when a patient isn't fully satisfied, I'll ask them, how much of your life does your vision bother you? And when they're thinking about it a lot, I know that it's something that I need to do something about. So first of all, it happens with history. And then I got to figure out, is there's something wrong? And after we do the, front to the back eye health, including macula and optic nerve, and everything looks good eye health wise, we need to quantify. And I like to quantify optical scatter, to tell you the truth, with a few different devices. We use the OPD3 scan. We also check wavefront, and I have the eye trace. And so we quantify optical scatter after we make sure that the eye health is good. But we can actually quantify it after, if a patient is dissatisfied.
Great. And Rosa, what percentage of patients are excluded from current IOLs in your practice for premium lenses? Which ones is there, can you give us a sense for how many patients do you exclude from current presbyopia correcting lenses because of, some specific feature of them that may not fit for your patient?
Well, patient expectations are key, and if their expectations exceed what any IOL can give them, then they need to be excluded because they'll never be happy. That's a whole different scenario, and versus an anatomy issue that could exclude them from a presbyopia correcting IOL from the practice. If there are corneal abnormalities that would cause issues with creating increased halos or glares or dysphotopsias, then I think that I would exclude them from a PCIOL. And also anyone who has advanced glaucoma or macular issues, I would exclude. And obviously cost also plays an issue depending on the patient demographic.
So I'm going to go down the panel here. What percentage of patients fit that bill? What percentage of patients do you say this is not a candidate patient because of halo glare, expectations, medical issues, or something else that you say this is this is not going to fit your patients? So we'll start with Rosa. What percentage of patients?
Probably about 30% of patients are excluded.
Liz?
I'd agree. I would say 60% qualify, but only 10% convert. So there is some gap there, but certainly there is a much larger group that cannot get it for different reasons.
Eric?
Yeah, I'm going to go with I would exclude 40%. I'm a little more fastidious than Rosa. She'll operate on anybody.
I'm not even going there.
Yeah.
Go team quality.
Yeah. And Vance.
Well, in the current atmosphere, I exclude 30% also for multifocality, but I also do the light adjustable lens, and I would put that in the premium category. Mm-hmm. So I do have an answer for the patients where I don't want to reduce contrast further. But 30%, I agree with Rosa and Liz.
Got it. Great. Yeah, and I think that's probably in line. Somewhere between 30 to 40% of patients, don't qualify for various reasons. A couple more panel questions here. So Team Angels Without Halos. And so can you briefly describe a patient where you had an issue with a presbyopia correcting IOL, where the patient had issues with quality of vision postoperatively?
Yeah, I'll take that on, Sam. And I think this is probably something that almost everyone who's listening has had this patient experience, is you operate on somebody and they complain of quality of vision issues afterwards. And the problem with this is that patients who have presbyopic IOLs kind of expect to have good reading, but they demand good vision. And if you can't give a person good distance vision, even if it's not correct, even especially when it's not correctable by glasses or contact lenses, they're never going to be happy with their quantity of vision when they have a problem with their distance. So vision starts with distance vision, and the reading becomes the added value here. So these are my most frustrating patients, and I think that's the number one reason why a lot of ophthalmologists don't implant those presbyopic lenses more commonly, because they've had a patient or two who's just been so unhappy and wasn't correctable because of quality of vision loss.
Mm-hmm. I agree. I mean, I think quality of vision in these patients, sometimes even though they get 20/20 distance and, J2 or 3 up close, it's just not acceptable to them. They feel like they're missing something. And so we know that vision is not just a Snellen acuity or a Jaeger acuity up close. So Eric, I agree with you. I think that we see this with current light splitting lenses, certainly less now than we did in the past. I think the earlier technologies that we had before were much harder on the quality of vision, and newer technologies are better, but still, when you split light, you're missing something. So Team Full Rangers, and maybe I'll address this to Vance. Can you briefly describe a patient where you had an issue with a presbyopia correcting lens due to quantity of vision that the patient had post-operatively?
Well, this happened more often, I think, with bifocal implants, because it just seemed like there could be some vision that the patient wasn't always getting. It's happened less with trifocal implants because it's answered the question for the quantity of vision for so many of them. As a matter of fact, anymore with the trifocal, it really is more about the quality issue, but quantity has gotten better and better over the years. And I agree with you guys that you got to nail distance, but after you nail distance, if they've invested heavily in advanced technology, they want that near image.
Yeah. And I think the quantity is, depending on which technologies you use. If you're using a low-ad multifocal, depending on where the patient lives, and I think some physical parameters, how long their arms are, a lens that, you put in Eric is going to be certainly different than a lens you would put in someone with shorter stature, just say Steve Lane. You have to be cognizant of those things as you go forward. For the record, I love Steve Lane. Okay. All right. I had to come up with a quick one there. So let's look at some data on the Juvene lens. And so we'll go through this, and as we look through the data, I'll sort of walk us through it a little bit, and then each team will have some questions for you, and sort of answer the questions with sort of your team. You're trying to make your team win here at the end, and there's a prize at the end. So let's get some good discussion here. So we're going to look at 6-month monocular visual acuity. So just to give you some context, these patients were done under what's called the GRAIL study. The GRAIL study was an exploratory study done in Mexico at 2 sites, and various surgeons participated in the trial. It wasn't very controlled, so it was more just to figure out the lens. How does it work? The company had some pilot eyes that were done previously, so safety wasn't as big an issue. But we're trying to figure out, how does the lens work in the eye? How do the patients do? And so this is 44 eyes at 6 months post-op, and you can see here they have very good vision overall. Nearly everyone is 20/40 or better at all distances. And as you move to the left, you'll see that 20/20 at distance, 82%, and then only 7% at near. But 20/25 at near for the monocular eye, and 75% of them got this intermediate vision of 20/25 or better. And then when you look at the binocular vision, you can see that there's summation here. So there was 13 patients, so 26 eyes that had binocular implants of the Juvene lens. And you can see here that the chart moves up across all of the parameters, looking at best corrected distance, intermediate, and near. So there certainly is some binocular summation. I do want to clarify that this was not a monovision effect. These are patients that are distance corrected, and then their visions are checked. So we disregarded any kind of monovision effect here. We tried to negate that when we looked at these patients. So Team Full Rangers, how would you interpret these data? And I'll go to Rosa here.
Well, I think it's very promising data. Obviously, binocularly, the lens really performs quite well, with distance and intermediate achieving greater than 20/25 vision, and then near at 62% is generally acceptable for a binocular result. Even at 20/30 is a very good near vision, 85% achieving it. But even monocularly, that's done quite well for 20/30 or better in most ranges of vision, if not all ranges of vision, is acceptable. So I like that range of vision, because in the past, especially with the bifocals, but even with some of the multifocals that are out there, you'd lose either some near or some distance, and you'd have to do a little bit, not distance, intermediate rather, is where really sometimes it was hard to hit the target with the multifocal lenses. So it's nice to see here that you are truly getting a full range of vision with this lens. Wouldn't you agree, Vance?
Yeah, I would agree 100%. You know, to see 20/25, you know, at distance, monocularly, and of course, binocularly, that's going to be someone with real quality vision. It's not like 20/30 monocularly and then binocularly it was 20/25. This is monocularly that many people doing that well. And then intermediately, that many doing that well. And to tell you the truth, at the 20/32 level for near, that's newspaper print. And these, and I would think, I mean, you guys, you know, are ahead of me on this accommodating lens journey, but I would think with time, they get even better with using these implants and kind of using their accommodative mechanism. But to have that many patients seeing newspaper print that comfortably is really impressive to me.
I think, you know, Vance, you bring up a good point. These patients do get better with time. We did see that, you know, it takes a little while for their eyes to get used to the optics, and we see that the visions do get better as the lens is in place. You know, there's no trade going on here, but Eric, you had a chance to go to Mexico to examine some of these patients. And there was a patient that I think you had a chance to sort of test. Can you sort of quickly describe how the patient's range of vision was when you made them read in low light?
Yeah, and that was the most impressive part of my visit. We went down to implant some lenses and to experience, but I saw some patients who were out 1 year after having had the Juvene lens implanted. And we examined a couple of patients, and what was remarkable about this was you know, I thought it might be a pupil effect with a small pupil giving them depth of field. The pupils were normal size. I had them look at distance. I had them look intermediate, and there was no blind spot. It was contiguous vision from distance to near the entire way. So I said, okay, this is pretty impressive, but let's really make it really tough on these people and see what happens. And I turned the lights down to a mesopic level where, you know, almost anyone would have trouble seeing up close. With a multifocal lens, you'd have no vision at all with this type of lighting situation. And the patient didn't bat an eyelash and just read just as effectively in low light as he was reading with bright illumination. He went right from distance to reading Jaeger 1 and up close in 20/20, as if this was just, you know, the expectation. He was literally reading and seeing distance like a 20-year-old.
And the other thing you see is that, as you mentioned, no lag. There's no delay in sort of the mechanism. He was able to translate from distance to intermediate to near, you know, without any kind of delay, which I think is interesting and impressive.
Right, and it just wasn't one patient. There were a couple patients that we saw like that. So it made a believer out of me.
Good. Okay. So the next thing we're going to look at is some more data here. And so this is highlighting what Eric was just talking about, which is mesopic contrast sensitivity. This is done without glare. So this is done on a system called the M&S system. And you can see here in the green is the normative data, which is a young, healthy phakic population. And then comparing the Juvene lens to a very, very high quality monofocal Tecnis IOL. And you can see that the curves are very similar between the Juvene lens, which is the blue, and then the Tecnis monofocal, which is in yellow. And as we move to with glare, you can see a very similar curve as well. So these patients, and we know that with age, you get a decrease in contrast sensitivity at higher frequencies. So the difference in performance is not due to aging, and the comparison between the Juvene lens, which we saw in the last slides, gives you great range. Now it's giving you really good quality of vision too when subjected to glare or in mesopic conditions. And then subjectively, these patients, again, the bilateral patients, were asked about their symptoms of dysphotopsia, whether that be halos, glares, starbursts. And this was a provocative questionnaire. It was directed, and they saw pictures of all these various dysphotopsias. And when asked, they, in an uncorrected state, so the average refractive error in these patients was about a -0.9. And uncorrected, they had a little bit of halo, glare, and starburst, which you would expect if you were a little myopic, which I am. At nighttime, I get these halos and glares around stuff. But if I put on a pair of glasses, they go away. And when we corrected their residual refractive error, their dysphotopsias sort of melted away. So team angels without halos. And I'm going to ask Liz this. What do you think of this data?
Really impressive information for a couple of reasons, but the monofocal that you chose to compare to is arguably the best monofocal from an optic platform, especially as it relates to higher order aberrations, specifically having the most negative spherical aberrations. So that plus what it's able to do with its ABI number and color vision and really fine tuning that quality of vision, that's a fantastic monofocal. So to be able to compare to that and see that the mesopic contrast sensitivity, even without glare, is so close, but with glare, other presbyopia correcting lenses, you just can't say that because the glare induces such a significant drop in the overall contrast. So to see what that appreciation, you can really appreciate the potential quality that this lens will clinically translate to, given what this data looks like. The most impressive data really is going to be the fact that the average myopic refractive error, the average refractive error was almost a diopter. You could never leave a light splitting technology with that kind of refractive error. They would be riddled with not just glare. I mean, it would be all sorts of starbursting and other issues. It's so important that with other light splitting multifocal lenses, you absolutely cannot you have to really mitigate that residual refractive error, and to see the tolerance here, that means a lot.
Mm-hmm. I agree. Eric, anything to add?
You know, I would just point out again, and Liz did a great job of this, but look how the graphs bifurcate when you go with glare. Look how much of a bigger difference there is. You know, glare is really the acid test for how well a lens works. And when you see under glare conditions that the monofocal lens and the Juvene lens really are basically superimposed on each other, tells you the real value of this lens. Under the worst conditions that we experience, driving at night in the rain with headlights coming at us, that's when patients are really challenged to see well. And what I'm seeing from this is that this lens is giving almost identical vision to, as Liz said, the best monofocal lens we have available on the market today.
Yeah, and then, you know, coupled with the subjective responses from the patients where, you know, right. Obviously the testing of contrast, you know, is one thing, but then when you actually get the subjective sort of confirmation of that, I think is really quite exciting. Okay, so let's see here. So we're going to look at some defocus curves, everyone's favorites. So this is a monocular defocus curve for the Juvene lens. Again, the same cohort of patients. And what you see here is in the blue, which is the monocular defocus curve for the Juvene. In the yellow is the monocular defocus curve for the Symphony from their SSED submission. And then in the gray is the Tecnis monofocal IOL. And you can see here that the monocular defocus curve for the Juvene is, you know, essentially 20/20 for distance. Intermediate gives you 20/25 and near of 20/40. And you can see quite a bit of drop off at near compared to, you know, the most popular extended depth of focus lens that we have in the US. And then when you look at binocular data, you actually get a little bump in the distance vision, as well as the intermediate and near. So again, binocular summation that we see with this, even more so than we see with either of the other two platforms here. And
really,
so
really impressive data, boy.
Yeah, when we compare, Vance, I'm getting to you, my friend. I'm getting to you. When we compare the monocular and binocular defocus curves, you know, you can see here that there's nearly a bump of a line between the green, which is the monocular curve, and the binocular curve. So Team Full Rangers, and I'll start with Vance, what do you think about this?
Well, you know, I haven't had the honor of implanting this lens yet, but I have, you know, 25 years of premium implant experience, and we've always dreamt of what you're showing us. When you see that contrast sensitivity, you know, I kind of, when I'm talking to my patients, you know, I talk about the vision of a 10 or 15-year-old when they have beautiful contrast at night and they have this full reading range of vision. And that contrast sensitivity is starting to give the low light image quality of someone in their younger years. And when you come, but you just would never imagine that you would get the reading range along with it. And that's what's showing the accommodative ability of this. And I feel like I'm seeing the future. And I've dreamt before my career was over that I would be putting in accommodating lens implants. And the binocular summation doesn't surprise me at all. We see that with our natural accommodation too. So many things here point towards a restoration of our natural accommodative ability. And it's a super exciting technology.
And Rosa, anything to add?
I really have nothing to add other than this lens seems to be able to give us, as Vance said, everything we've been waiting for. It gives us the defocus curve of that is better than an EDF IOL, that is showing that through the ranges and with some forgiveness. As Liz said, most multifocal, trifocal lenses wouldn't forgive a diopter of refractive error with the dysphotopsias and visual issues and the contrast sensitivity that we want. So it seems to have everything to bring it together and make it the ideal lens for a patient.
Yeah, I mean, I agree. I have had the opportunity to put the lens in, and we'll show a video of that later, actually, so you can see how the lens goes into the capsular bag and the process of sort of putting it together inside the eye, which is quite intuitive, actually. But the results that we see are actually they're really impressive, and you know, this is very it's very real data. It's not cooked in any way, and you know, that's one thing that people ask: is this really true? And the answer is yes. And you know, and we've seen it from multiple surgeons who have been implanting the lens, and so overall, super exciting in my mind.
Yeah.
So, go ahead, Eric.
Yes, Sam, if you go back and you look at that, what you're seeing here on the defocus curve, and the focus curve, I think you kind of mentioned that a little bit. So people's kind of eyes kind of glaze over when you talk about the focus curves. But what you're showing here is basically a graphic representation of what I experienced in looking at the patients when I saw them. This is what my patients experienced when I was down in Mexico evaluating their near vision. It was exactly what you're seeing here. So it's nice to see that the focus curves actually correspond exactly to clinical experience.
And what's nice to, sorry, Sam, what's nice to see here is the intermediate vision at 66 centimeters, which is very workable distance. It's not too far away or too close. It's right where people keep their desktops or their laptops or hold their PDAs as well. So I think the intermediate vision here is also very impressive.
And I think Eric brings up a good point. You know, when you look at a defocus curve, you don't want to just look at the points where you're interested, which is distance, intermediate, and near. You want to look at the actual curve to see, you know, if you're able to maintain that shelf and if, you know, how the decay is. Because, you know, if it goes really high at distance and dips down and then goes high at intermediate and dips down and goes high at near, yes, you can see at all those distances, but but you're missing everything else. And what you see with this is a continuous range of vision, which, you know, we can only see in a defocus curve. And all the points are the points that were tested. So, you know, it's not that we just went from, you know, distance to intermediate and we just drew a line. The points were tested in between to create that curve. So PCO. PCO is, you know, certainly something that we see in all of our current lenses right now. These patients, you know, starting from when the company first started years ago, and there was some patients done in Panama to sort of just, you know, get some early data on it. And then the Grail eyes, you know, what we've looked for is PCO in these patients. And 53 patients from the pilot study and Grail eyes were examined and graded, and showing no evidence of opacification. So no YAGs have had to be done for a PCO in these patients. Correspondingly, there's been no evidence of lens fibrosis between the base lens and the fluid lens. And all eyes retained their range of visual acuity, distance, intermediate, and near. And when I refer to those all eyes, recently, we went back down to Panama to look at the patients that were done early on to see, hey, you know, those patients were only followed for a couple months. What's happened to them now 5 years later or 4 years later? And you can see here all the way to the left, this is an example of a patient that was done 54 months ago, more than that now. And we know that it's an original version of the lens because there's no blue ring for the base and there's no yellow ring around the fluid lens. And you can see here that the capsule is pristine, and then working your way back 33 months, 22 months, and now to the current generation of the lens at 6 months. So no PCO noted there. This study was just recently completed at the Mariana Eye Institute by Dr. Liliana Werner, and this was a contralateral rabbit eye model. And so the rabbit has a very high rate of fibrosis. And it's a model that all IOLs use to sort of grade how much PCO happens. And so the bottom lens, which is the control lens, these are two different rabbits. So top being the Juvene, the bottom being the control. The bottom lens is the Acrosoft lens by Alcon, and the top is the Juvene. This was done, I believe, 12 times, you know, 12 different rabbits, and in all of the eyes, basically no PCO was noted. So Team Angels Without Halos. What do you think about this? And I'll start with Eric here.
Well, you know, I think a clear capsule sounds originally like it's a small benefit, but I would suggest that this is an added value that is extraordinarily important to think about. Having a clear capsule means that you don't have to do YAG capsulotomies. It means that there's very little change in effective lens position because it's a capsule filling lens, so that there are going to be more reliable refractions. And you're not going to get the vitreous detachments, you're not going to get the floaters, you're not going to have the issues with potential retinal detachment from the vitreous coming forward. So I think there's an enormous value in having a lens that protects the posterior capsule and keeps it clear.
Yeah, I agree. Liz, anything to add here?
Sure. I mean, just to dovetail on Eric's point, yes, PCO, we see it and we get it. The bigger piece of this is the actual fibrosis that occurs around the lens. It's those same epithelial lens that proliferation that'll occur anteriorly. There's nothing worse. You have a great patient who's plano, and we've seen this, Doug Koch has published on it, but by 1 week and 1 month, there's like a, one diopter shift, and it's because the lens itself has shifted, and it shifted from healing, but because there's a shrink wrap effect going around a flat lens. So that's such a huge part of being able to provide a longevity in patient satisfaction, knowing that whatever you're placing in them, that refractive error, if it's residual 0, it's going to stay 0, and there's going to be a quality to that long-lasting vision without the change in overall in time.
Yeah, and I think the one thing that we're seeing with these patients is, by lack of PCO, you're actually keeping the bag alive. So you're maintaining the same whatever result they're getting, they're keeping that. So this was evidenced by those initial patients that were done 4 or 5 years ago, whatever accommodative amplitude they had at that point, it was the same when it was tested a few months ago. It didn't decline over time. So they didn't get PCO, but the effect of the lens maintained, which I think is really exciting, because as you look at a technology, you want to make sure that you're able to promise a patient or talk to a patient that, hey, this is what you're going to see now, but you don't want that effect to wane over time. And I think if there's fibrosis in the bag, that could be a risk, but if you don't see the fibrosis, that perhaps will allow for the lens to maintain its effect over time.
Good point.
Team Rangers, anything to add here?
I would just add that, over the years, we've all put in implants that you can see various stria and irregular forces going on in the capsule. And we saw very aggressive capsule opacification with some of those lenses with very, very high YAG rates. And like Liz said, not unusual for a change in the lens position and a change in refractive endpoint. To see, I think our lens capsule really wants to be filled, and it's almost like it's in its happy place with this lens. And I love the way you put it, Sam, it stays alive. And so I imagine it stays more supple. And I think that we may see other benefits. I'm just surmising here, but I know when we remove the natural lens and put in a traditional implant, that posterior capsule shifts forward more often and further than we think. And there's a shift in the vitreous that goes along with it. So the stability of the lens vitreous interface, I think, could have some other benefits too. So I think it's really exciting to see how happy the capsule is being filled the way it was before, cataract surgery.
Yeah.
Yeah, I think that's a wonderful point. And I think that everything that I've learned about medicine is that maintaining the anatomy is the key to a good result. And what this lens does is it maintains the normal anatomy of the anterior segment, which is completely different than what happens when you have a monofocal IOL that basically just has width and length but doesn't have depth. Mm-hmm. So I think it's an enormous value that we sometimes underestimate.
Yeah, and I think Eric brought up the point that you're maintaining the capsular volume, and Vance brought this up as well. By doing so, then you get the less vitreous contraction, which could have safety benefits, with respect to PVD creation, floaters, and then possible retinal detachment. And we'll find that out as we use the lens more. Let's see here. Okay, so other attributes of the lens. So we talked about this, the ELP of the lens. So this was done using UBM, looking at 44 eyes, and we had 34 eyes actually that we could look at the UBM. And what we looked at was, was there any difference between the 1 month visit and the 6 month visit between the distance between the back of the cornea and the front of the lens. The average amount of movement was 0.01 millimeters. So really, really small. Standard deviation about 0.12. The absolute change was 0.09 millimeters. So less than 1/10 of a millimeter change in the ELP for the lens. Rotational stability, the goal is that this lens will have a toric version as well. And so we have toric markers on the fluid lens, and we were able to image these and compare them to images for where they were placed. And at 6 months, there was 0.71 degrees from baseline with a standard deviation of 1.23 degrees. So really, essentially no movement at all. 100% of lenses there was no lens that rotated more than 5 degrees, essentially. And then the refractive stability, which is correlated to the ELP, we can see that the refractive stability is very, very tight here. At 6 months, 94% of patients had a refractive change of less than half a diopter. So, there's a little shift between 3 to 6 months, but overall a very, very stable lens. And this is done with a vector analysis, so a little higher bar than just looking at the manifest or the spherical equivalent. And so we see here that the lens is going in and staying where it's supposed to. So I'm going to have Rosa here then talk through the implantation of the lens. This is her first surgery.
Yeah, so this is my first surgery down in Mexico, and this is the base lens going in. And you think seeing it in the videos of the volume of this lens, it is a very forgiving lens. It's very soft. It implants very smoothly and under control. And you can see it sitting there within the capsular bag. And now I'm putting the fluid-filled lens. What's nice is the color contrast that occurs here. We have a blue base lens, and then there is a yellow rim that lets you know whether the fluid lens is upside down or the correct way, which it is the correct way here. It inserts into the base lens, and then there are 3 little phalanges that you want to put the fluid lens just underneath to lock it into place. And this is my very first lens implanting it. I hadn't done any before. And this little device helps you put the 3 phalanges in. You just sort of have to nudge the lens into place. And then you just remove the viscoelastic. And there really isn't a large learning curve at all. The incision is very clean. It's not distorted at all. The lens centers very well and very easily. I didn't have to manipulate it at all. And it's very forgiving within the eye. It's very soft on the capsule and on the iris structures.
Yeah, Eric, you wanna give your impressions of the few cases that you had a chance to participate in?
Yeah, my experience has been the same as Rose's has been. I just didn't do it as well as she did. But other than that, I thought this was something that was very doable by any competent cataract surgeon, and I think it's a very controlled delivery, and I think it's absolutely genius to have the modular technology. I've been involved with 2 other accommodating lenses, and they all went in through 4mm incisions because they were large apparatuses that had to go in through a larger incision. Because of the modular Juvene IOL, it goes in through a 3, maybe even a little smaller than a 3mm incision. So it's a very nice self-sealing incision, which is really what we want as cataract surgeons.
Yeah, and the incision doesn't need a stitch. Because the lens, when it goes in, it just sort of fills the bag and stays there. I remember when I first got started with crystal lens, they said, hey, put a stitch in because you don't want to pop forward. This is sort of, as much of a plug and play lens as you can have when it comes to a lens that's shape changing.
What's nice about this lens too, if we can go back to the PCO and the fibrosis study that we had seen, is that where you put this lens is pretty much where it's going to stay. That's why it's not going to rotate. The fluid-filled lens is within the caps, the base lens, and that base lens is going to stay there too, because fibrosis isn't occurring. You said crystal lens, and when fibrosis did occur, you had some complications with some of the lenses. They can shift, they can tilt, they can move forward, but because fibrosis doesn't occur here, you're keeping it maintained within its space. You're still getting the ciliary body being able to move it, and you're going to maintain that accommodative amplitude throughout with a lens that stays central and stays where you put it. And that's why you have such tremendous stability and refractive competency with this lens.
Yeah, it really does. It stays where it's supposed to, which is a great attribute. Okay, so comments on ELP or the surgical technique. Vance and Liz, you haven't had the opportunity to put this lens in yet. What does it look like? It's going to be challenging to you. What do you think about the video? Obviously, it was done by an expert surgeon, but how do you think this is going to translate?
Well, I've seen Rose's video, and that's beautiful, but I've seen your video, and even under your hand, Sam, it doesn't look like it's that hard to do. No, but
you bring up a good point. You bring up a good point.
But in all seriousness, the one other factor that we didn't talk about too, which we've kind of peripherally discussed, is the fact that there isn't fibrosis also supports the idea that there's a really nice biocompatibility with this lens, right? With inflammation, you get fibrosis, not just the fact that it's bag filling, right? It can be bag filling, but inflammation will induce fibrosis as well. Sure. So while there might look like, yes, there is more hardware simply because it's not the one-piece lens that we're used to, but the attributes of this is that it is that truly disruptive technology that we're looking for, which is that, you know, overall range of vision, that we can have that landing spot with even a small refractive error. They can still have that high quality vision without necessarily forsaking their near vision in the process.
Yeah, and you know, to dovetail on what you said with inflammation, the rabbit study, you know, those rabbits were sacrificed and they looked for inflammation, and there was no inflammation noted with the lens inside the eye. Vance, any comments here?
Well, I thought Rosa's video was absolutely stunning. I mean, and great job, and it really makes it something that I feel like we're going to just feel real comfortable, you know, surgically. What I get even more excited about is, you know, just so many years of assessing eyes on which ones can take multifocality and which ones can't. And beyond that, which personalities can take multifocality and which ones, you know, we should be wary of. And the pressure that this takes off of us, you know, to be able to get such quality distance near and intermediate, it makes the skin tingle thinking about, you know, doing this for patients when the surgery looks quite straightforward and the optics are so pristine, and there's no, you know, I predict there's a lot less adjustment to getting used to your new vision because there's, you know, no dead spots or anything like that. So bravo, wonderful surgery, Rosa. It's a joy to watch.
So Vance, I think you might have seen these slides before because you're about to answer my next question, or you're getting to it. So, you know, I'm going to ask each panelist, where do you think the Juvene, as we've seen it so far, where do you think this will fit into your surgical armamentarium? We'll start with you, Vance.
I got to tell you, for me, I mean, obviously, we need to finish a clinical trial and prove safety and efficacy in larger numbers of patients. But if we can make this data carry through in a larger clinical trial, the only reason a person wouldn't do it when your contrast sensitivity is so good and your range of vision is so good, I truly believe that an implant like this isn't just about seeing without glasses. I mean, there are issues with bifocals and trifocals. And so to restore both functions that we lost in our lens, clarity and reading range, with a lens like this, yes, we may have a third group of people that want to do everything without glasses, but I think even glasses people will want this. And with that, again, contrast sensitivity beauty, I think financial would probably be the only reason I wouldn't do it for someone.
Liz?
I absolutely agree with everything that Vance has already mentioned. I mean, certainly what this is exciting, a few reasons, but number one, simply the fact that we don't have to worry about those positive dysphotopsias as being a sensitive issue of why we wouldn't consider this lens. But it also opens up those with different ocular comorbidities that have decent visual potential, and post-refractive surgery patients, like that post-RK patient who has fluctuations in their vision. This is the type of lens where they could have consistently better vision throughout the day, even if it means that they're sacrificing some near because of the hyperopia that occurs as the day wears on, but they don't sacrifice quality of vision in so doing. So certainly, I mean, as Vance mentioned, yes, cost is an issue, but patient education and the conversation piece will be a lot easier. As I mentioned earlier, sometimes I spend more time on the side effect profile, particularly if it's a personality concern. I'd be much less concerned in utilizing a true accommodative lens like the Juvene.
Mm-hmm. Rosa?
I have to agree with everything that's been said so far, and I'm going to agree even more heartily with Liz on the comorbidities coming in now. I don't think I'd have such an issue even putting this lens in an AMD patient or a more advanced, moderate to advanced glaucoma patient, because we're not decreasing contrast sensitivity. We're giving them the vision that they need, and we may be giving them a range of vision. And specifically in the AMD patient, you may be also giving them a bit of magnification for the near that they may require as well. I think what's really outstanding about this lens is the modularity of it. And so if for some reason something is off, if you have a cornea that is changing, like your RK cornea or something, and you need to replace the fluid-filled lens, either be it adding a toric component or taking away the toric component or something like that, we can do that with this with minimal effect on the eye. You're not deflating the capsular bag at all, because the base lens always stays in. You can take out the fluid-filled lens. And I think that is a very strong point of this lens, is the modularity of it and the different things that can occur with this lens. I think already for just 54 eyes, we're seeing tremendous results. And I agree with Vance, we need to move forward in the FDA studies and have more stringent studies around this. But I think if this is where it started, can you imagine where it's heading? Because we're just improving everything. And that's where I see this growing, and we're gonna even get better results from it, is what I'm hoping for, because those were preliminary studies. And moving forward, we've already nailed down so many of the things that were nuances with this lens.
So I would like to share before I go to Eric, that the company did submit their IDE to the FDA. So that's a huge milestone. Eric, we talked about 30 to 40% of patients not being candidates for our current presbyopia correcting lenses. So as you answer this question, maybe you can address that. How much would that number shrink as if this lens was available?
Well, I think what's been said is true. The comorbidities that we dealt with before, the psychological issues of people dealing with glare and expectations will all be met. I think the only patient who wouldn't be a candidate is a patient who doesn't have an intact capsular bag or has, zonular weakness. Might be the one patient I might not want to put this in, but glaucoma, macular degeneration, monocular patients I wouldn't put a multifocal lens. I'd be very comfortable here. I think what's going to change completely with this lens is that this lens will become the ideal refractive lens exchange, IOL. And right now, I think most of us, 95% or more of us are doing cataract surgery on patients with cataracts, and clear lens extraction has become a very, it exists. I do some, but it's not a major part of the practice. I think this will turn everything around, and I think that this may be the lens that, when you become presbyopic, this is the lens that you would go to right away, and we don't wait to get a cataract. This would be a lens that I could see putting in a 50-year-old with a clear lens on a routine basis. I don't put in multifocal lenses in plano presbyopes. I just don't think that the results are good enough to warrant that right now. But this is a lens that if someone came to me who was plano at distance and had lost their reading, if these results hold up, I wouldn't hesitate to do a clear lens extraction on this type of patient going forward. So it opens up a whole new avenue that we haven't seen before that dwarfs the magnitude of the cataract surgical patients we're taking care of now.
Just to clarify, Eric, for Liz and my benefit, can you explain to us what a presbyopia patient is? more for Liz than for myself. Okay.
That was a cheap shot to three of us.
Oh, well, I'm sorry. I meant to include Rose on that as well.
No.
So,
I am a presbyope.
So which team wins, quality or quantity? Well, I think the winner is obviously both. We know that it's both, right? From a patient's perspective, spectral independence at all distances in low light and low contrast situations is ideal. From a surgeon's perspective, an IOL that we can meet the expectations of our patients, a procedure that is similar to what we already know and are comfortable with, and chair time that is similar to a monofocal IOL would be ideal. And certainly all the safety benefits that we have, including refractive stability, low rate of complications such as PCO, floaters, hopefully RD, will be really important for us. So, right now we're without sports, and it's really hard. This was as close to sports as we get right now for ophthalmology. And there's been this great show that's been on ESPN called The Last Dance. And I don't know if you guys have watched it at all. Have you guys seen it?
Yeah.
Yeah, I think it's really well done. So, you know, we have the dream team here, and the dream team includes Eric and Rosa and Liz and Vance. And Liz and Vance, by the way, are going to be two of the early sites for the FDA trial once we get going with that. So super excited to have them on board for this. But part of the, you know, the center of the dream team here is the CEO of the company, Ram Rao, who's really put, you know, so much time and effort into this. And you know, with this technology, we think that everyone's going to be a winner because we're going to have satisfied patients. And with that, I'll take any closing comments from the panel. And I really want to thank you for taking time out of your schedules, especially now that we're ramping back up for participating in this.
I'll just say I'm really excited to, you know, be, you know, in the clinical trial for one, but to, you know, have this eventually in our, you know, armamentarium. I just see it as a game changer. You know, I'll just put a little bit of a dream out there, and maybe you guys have talked about this, but to have a capsule filling implant for the potential pediatric population could be a dream also. And so just the physiology of it is exciting, besides the wonderful visual outcomes. And bravo on your early results. Let's get this FDA approved.
Yeah, thank you. So thank you guys again. If there's any questions from any of the people watching, you can direct them to Ram Rao, and his email is rrao@lensgen.com. Thank you, everyone. Have a wonderful night and be safe.
Thank you.
Thank you.
Okay, bye, guys.
Thank you. Great job, Sam.